I'll stop mine and we'll switch to yours.
Perfect. Give me one quick second to let this go through. We have to play the up and down game with wonderful Zoom here for a second, but it will come up in just a second. Oh, come on. And Jean, take it away.
I spelled her name wrong. Sorry, Jean.
Okay, hi everybody. My name is Jeannie. I go by Jeannie. You say Jean, and I think I'm in trouble. I came from a very staunch Catholic family, so it was Jean Marie Catherine Flaherty, and I then quickly adopted, probably around 3rd grade, Jeannie, just to get that off my back. But today we're going to talk about dementia. We're going to just barely touch on delirium. And a little bit about the differences between the two. And then we're going to talk about behaviors, and specifically they're called BPSD, or behavioral and psychological symptoms of dementia. And so worldwide, there are about 50 million people right now that have dementia, and there's a new diagnosis every 68 seconds. And so let's start with asking ourselves, what is dementia? So next. So what is dementia? Is it memory loss? Is it memory loss with incontinence? Is it memory loss with irrational behaviors? Is it forgetting where you put your keys? Or did you put them in the freezer and you can't recognize them? Lots of big differences. Sometimes we think, oh boy, I'm having a dementia moment or a memory loss moment because I lose my keys frequently, or I lose my debit card 3 times a year. It drives my husband nuts. But there is a difference between normal aging, and there's a difference between mild cognitive impairment, and there's a difference between dementia. And so we're going to differentiate between those, and we're also going to talk a little bit about memory preservation tactics next. So normal aging, the normal aging trajectory is here on this slide. Excuse me. Hang on a minute. So this may seem a little bit odd to many of you, but especially knowing that our brain isn't fully developed until we're in our 20s, we are actually at our highest cognitive reserve at the age of 20. Now, many of you may feel a little bit depressed by this because it is truly downhill after this, but be assured that there are protective factors that can help. Next. So mild cognitive impairment, this is a slide that shows the trajectory of mild cognitive impairment. And this, on the other hand, is a stage between what may be normal cognitive decline that comes with age and the more serious decline of dementia, which is progressive. Mild cognitive impairment is not progressive, but dementia is. MCI, or mild cognitive impairment, differs from dementia in that the decline is stable and there is little to no effect on activities of daily living. So that's really important, because we have mild cognitive impairment where we have some expected age-related memory loss, but we still are able to take care of ourselves. We're able to toilet ourselves, dress ourselves, feed ourselves, bathe ourselves. We're able to take care of those activities of daily living. Next. So by definition, mild cognitive impairment is an intermediate stage between the expected cognitive decline of normal aging and the more serious decline of dementia. It can involve problems with memory, language, thinking, and judgment that are greater than normal age-related changes. But again, the biggest difference is that there's no significant effect on activities of daily living with mild cognitive impairment. Now, mild cognitive impairment may progress to advanced dementia, but it may not progress at all. Next. So this is our trajectory on dementia. So here you can see an unstable progression of cognitive decline. that defines dementia. So you're going along, and then all of a sudden you have this steep trajectory that signifies a dementia. And so, for example, slow and insidious in presentation, lasting anywhere from 8 to 20 years with a person with Alzheimer's type dementia, making it very costly and burdensome for families. Next. So dementia by definition is progressive, where mild cognitive impairment is not. It is degenerative brain dysfunction, including deterioration in not only memory, but concentration and language skills, visuospatial skills and reasoning that interferes with a person's daily function, those activities of daily living. And it is not considered a normal part of aging. Next. So here's a small table that just goes through the differences between delirium and dementia. Now, also don't forget that you can have a demented patient who is experiencing an acute delirium. So how do we know that? Well, we need to know that person's baseline behaviors. We need to know, yes, they may have a dementia, but are they experiencing an onset of delirium? That onset of delirium would be a significant change from their baseline behaviors. And so onset is abrupt with delirium, where dementia is insidious. The only type of dementia where the onset may not be insidious would be a vascular dementia. In fact, if there is a sentinel event, such as a TIA or a cerebral vascular event, then or accident, excuse me, then you can have an acute onset of dementia as a result of that. The duration of delirium is typically hours to days, and dementia lasts months to years depending on the type, and we're going to go through some of those types. And then attention is impaired with delirium, but it's normal with dementia until the very late stages of dementia. Consciousness is fluctuating with delirium, and there's 3 types of delirium. You've probably learned about these already in your courses, but there's hypoactive, there's hyperactive, and then there's mixed. The mixed is where you have more somnolence during the day and more agitation at night. So consciousness is fluctuating again in delirium, but you have very clear consciousness and very ordered speech with dementia until the very end stages. But the speech with delirium is incoherent, okay? Okay, next. So I'm talking about Alzheimer's here, but really any type of dementia patient that you're working with, I want you to recognize that there's always 2 types of, or there's always 2 patients involved. There's the person with the disease themselves, the care recipient, and then there's the caregiver. In fact, it is said that if we are blessed into our 8th decade of life, there is a 1 in 2 chance we will develop Alzheimer's dementia. And if you are not someone who develops it, it is your chances of being a caregiver for someone with Alzheimer's is just as high. So that's not very uplifting, especially after I heard you just had an exam. But here's what I have to say. We do have some protective factors that we can certainly address today. Next. Okay, so some of the most common types of dementia, the most common type of dementia is Alzheimer's type disease. So understand that dementia is an umbrella term, and there are several types of dementia, and Alzheimer's is just one type, but it's the most common type, comprising of between 65 and 85% of all dementias. And then it's the 6th leading cause of death in the United States. And the second most common type of dementia is vascular dementia. And this type of dementia is a general term describing problems with reasoning and planning, judgment, memory, and other thought processes that are caused by brain damage from some sort of cerebral vascular event, meaning that it can be acute in onset. But even again, as I said earlier, if there's no sentinel event, the long-term effects of cerebral vascular disease can lead to vascular dementia in a more insidious form. Unlike Alzheimer's, vascular dementia can be diagnosed through CT or MRI with evidence of vascular damage. A person may also have a mixed dementia, So this would be where they have Alzheimer's type components, and then they have vascular comorbidities that support a vascular dementia. We want to be very keen on identifying when memory loss started, the evidence of its progression, and essentially what came first, the vascular event or the memory loss. And that's how we would determine if it was a true mixed. All right, let's talk a little bit about Parkinson's dementia. I just wanted to ask also, Dr. Teets, is that correct?
Yep.
Are you monitoring the chat box?
Yes.
Okay, I just want to make sure I'm not missing anything. We can certainly have questions after if you want. I realized there's 146 participants, so I didn't know how you wanted to handle that.
Sure, yeah. The chat box is open, but I don't see that anyone said anything in it.
Okay,
Questions.
okay, thank you.
Yep.
So Parkinson's dementia is actually a type of Lewy body dementia because it involves abnormal microdeposits called Lewy bodies in the brain. And just because one has Parkinson's disease does not mean necessarily that they'll actually get dementia. In fact, dementia only occurs in between 50 and 80% of those cases. And some studies have reported that the average time from onset of Parkinson's to the development of Parkinson's dementia is about 10 years. So this is an extremely important piece to know, because if dementia symptoms occur within 1 year of movement symptoms, the issue is likely Lewy body dementia, not Parkinson's disease as the diagnosis. So again, we want to know the onset of motor dysfunction, and we want to know the onset of dementia or memory dysfunction. And then, so Lewy body disease as a primary diagnosis only accounts for about between 5 and 8% of all dementia patients. And as with other types of the dementias, there are no single tests that can be conclusively done to diagnose Lewy body or Alzheimer's for that matter. So today, Lewy body dementia is a clinical diagnosis, which means it represents a provider's best professional judgment about the reason for the person's symptoms. The only way to conclusively diagnose Lewy body is through post-mortem autopsy. Common symptoms, however, that occur with Lewy body that I see in my patients and I hear about are hallucinations. They can have some fluctuations with consciousness, and they have extremely disrupted REM sleep. And so they usually come to me and they'll say, their caregiver or their partner or their spouse will say, they're violent in bed. They have horrible night terrors. They beat me up. They end up getting up. They're completely delusional. They're hallucinating. This would be someone that I would definitely start thinking more about Lewy body dementia than Alzheimer's. Now, here's another thing. If someone actually gets diagnosed with Alzheimer's type and they're having behaviors and psychological symptoms of dementia, those can be hallucinations, delusions, agitation, wandering, picking. They can have both tactile as well as auditory and visual hallucinations. These types of symptoms of BPSD are oftentimes treated with antipsychotic medications. Even though there's no FDA approval for the use of antipsychotic medication, they're still pretty commonplace. But if you give somebody with Lewy body dementia an antipsychotic, they go off the wall. So if they get 20 times worse in their behaviors, we may need to consider that they don't have Alzheimer's type dementia, but they actually have Lewy body dementia. Many experts believe that Lewy body dementia and Parkinson's disease dementia are two different expressions of the same underlying problems with brain processing, but most experts commend or recommend continuing to diagnose Lewy body dementia and Parkinson's as separate disorders. So the diagnosis of Lewy body dementia, specifically when dementia symptoms are consistent with Lewy body dementia that develop first, so dementia before motor dysfunction, when both symptoms, dementia symptoms and movement symptoms are present at the same time of the diagnosis, or when dementia symptoms appear within 1 year after movement symptoms. Okay, next. Oh, I'm sorry. Can you go back? I apologize. We're talking a little, I forgot to go back. Sorry. So let's talk about FT dementia or frontal temporal lobe dementia briefly. So the nerve cell damage caused by frontal temporal lobe leads to loss of function in these brain regions. This causes deterioration in behavior, executive function, decision making, difficulty producing and even comprehending language. And this leads to symptoms of prominent personality changes and typically occurs between the ages of 45 and 65. The sad prognosis of FT dementia, and I don't even know how many I have. I probably have 15 frontal temporal lobe dementia patients right now. They are all under the age of 60. They are all in memory care, and their trajectory is between 5 and 7 years max. It's a very, very fast trajectory. Diagnosis can be made of FT dementia upon MRI demonstrating some frontal temporal lobe atrophy in conjunction with clinical presentation. And then Creutzfeldt-Jakob is very rare, but I have seen it twice in my practice in the last 8 years as an adult geriatric nurse practitioner. And unlike other dementias, its progression is pretty rapid and death usually ensues in 1 year. Pick's disease is just an older term for frontal temporal lobe dementia. And we can't forget about normal pressure hydrocephalus, which presents in the 6th to 7th decade of life. And they have this triad of symptoms that are kind of, it's a little bit more of a rapid onset of dementia, urinary incontinence, and gait disturbance all at the same time. And so we have to really be cognizant of those factors when we're looking at.
Please select a wash.
Sorry?
Someone's not muted.
Would you like a receipt? Press yes or no. Thank you for using. Please wait. The wash
Brendan,
is.
you're not muted.
It's okay, no worries. So those are just some types of the dementia. What I did not cover here that I'll cover on the next slide very briefly is, next slide. So this just goes through the dementia subtypes that we kind of covered, but we also have alcoholic dementia. It's also referred to in the medical nomenclature as mushy brain, alcoholic brain, and then the most common cause of alcoholic dementia is a B1 deficiency, referred to as Wernicke-Korsakoff syndrome. So this syndrome occurs most commonly in the 6th decade of life, although I have a patient who's 32 who has Wernicke-Korsakoff. These patients end up having a severe B1 deficiency, thiamine deficiency, because of the inability to break down and metabolize its use, and then they stop drinking and the dementia has already done its damage, and so now they are in this demented state, but they're not going to die from dementia. They're going to die from other cognitive other comorbid states as they get older and older. The reason why I say the 60s, the 6th decade of life is most common is because you typically see patients who are functional alcoholics most of their life. They work, they carry a job, they have a family, and they like to socially drink, or they have a few drinks at night. But then they retire, and that's what happens typically in the 6th decade of life, is that they retire, and now they don't start drinking at 4 in the afternoon, they start drinking at 11 in the morning. And so it goes it becomes twice as much intake as it was prior to retirement. And then the other one that I don't have on here, but I'll just mention, is CTE. You'll definitely see this. I have 2 cases of CTE. I take care of both our retired Broncos players who developed it because of repetitive concussions. And that's a very, very unfortunate diagnosis. I don't know that much about the disease, but we're going to talk more about how to take care of these patients and how to work with these patients as we progress here. Next. So risk factors for dementia include age. In fact, that's the #1 risk factor. CTE, okay, stands for chronic traumatic encephalopathy. It's, if you haven't seen the movie Concussion, it is a pretty good media exemplar of the sports figures who developed CTE as a consequence of multiple head trauma. So I hope that helps. So again, age is the number one risk factor for developing Alzheimer's type dementia. There is a family history component, including the ApoE or apolipoprotein APOAE4 allele that makes it a genetic predisposition. Again, history of head traumas, that would be leading to CTE. Vascular disease we talked about can lead to vascular dementia. And then certain types of infections such as Creutzfeldt-Jakob, which again, it occurs because of the prion proteins accumulate within the central nervous system, and it's also known as mad cow disease. So what occurs in, we'll just briefly go over this, is like amyloid beta is produced normally within the body, but is cleaned up by glial cells during our sleep. So sleep hygiene is of utmost importance as a protective factor against Alzheimer's type dementia. So imagine these glial cells as janitor cells. They only come in and work when we're sleeping at night. Amyloid beta accumulation leads to the formulation of sticky amyloid plaques, and these plaques have been found to be present as early as the 4th decade of life. But they guess, I know you're not getting any sleep. I'm not either. I hear you. Sleep. The amyloid beta takes about 15 to 20 years of accumulation before symptoms actually present. And if the glial cells aren't able to work because we're not getting good sleep, they start building up in numbers rapidly, and this leads to increased inflammation, and that leads to synaptic death. So one other small piece of that pathophysiology is that aside from amyloid plaques, we also have the presence of tau proteins. They're normally used for neurotransport, but these become tangled within the chronic inflammatory state, and then this causes the neurons to choke from the inside out. Next. So this is where we get into the communication piece, is understanding Alzheimer's, because the majority of the patients that you will work with will have Alzheimer's, again, constituting between 65 and 85% of all dementias. What does an Alzheimer's patient look like? An Alzheimer's patient is someone where you walk in, depending on their stage, but they have a preserved long-term memory, but impaired short-term memory. And that's because of the notebook analogy. So memories are stored much like writing notes in a notebook. You need both a pen and a notebook. Page 1 is our earliest memories. So let's say this is page, we're about 3 years old. That's page 1 of our notebook. And page 100 is today. Page 100 is you taking the exam, you having avocado toast for breakfast, you getting 4 hours of sleep last night. That's page 100. Memories are stored in sequential order on subsequent pages, normally. The onset of Alzheimer's is when the pen begins to run out of ink. You're no longer able to add pages to your book because you don't have the hippocampal reserve for the ability to create new memories. Next, the pages become torn from the book, starting with page 100 and torn out slowly all the way through. This is where you have someone that I'll walk in and I'll say, George, it's so good to see you. My name is Jeannie. I'm going to be one of your nurses today, or I'm your nurse practitioner today. And and I may have seen him every month for the last 3 years. Thank you. I may have seen him every month for the last 3 years, but he doesn't remember me because he can't put a face or a name with my face. But he does remember, and this is the pretty incredible thing about dementia patients. They may not be able to tell you your name. They may recognize you until the end stages, but they do remember how you make them feel. They do. And knowing someone's first 3 chapters in their notebook is of extreme importance so you can be able to connect with them. So my next conversation with him is, he looks suspicious. He doesn't know who I am, even though I've known him for 3 years. And he will say, can I help you? And I'll say, did you go for a run today? Because I know in his book, in his early chapters, he was an athletic person. He used to run marathons throughout his entire life. He ran until he was probably 50. So I'll say, did you go for a run today? Now the Alzheimer's patient, George, takes a step back, considers, how does she know that about me? Because that's in his first 3 chapters. And I have aligned with what's in his first 3 chapters. So now he begins to say, I'm not so anxious. I'm not so paranoid. I'm not so suspicious. Maybe I can have a decent conversation with her. And then I can say to him, can you tell me what year you were born again? And someone with moderate, even to severe stage dementia that are still, verbal, will say 1941. They can do that. They can tell me what year they were born. Can you tell me what year it is now? No way, because that's probably page 110, and there is no page 110 anymore. In fact, we're probably down to page 50 now in the book. And so I have to gain information about my patient's history, their social history, their not just their medical history, but their social history, who was important to them, what did they do for a career, how many children did they have? Depending on where they are, they may not remember having children as much as being a child and looking for their own parents who have been deceased 50, 60 years. So that's kind of a good way to be able to communicate, is by knowing the first 3 chapters. Okay, next. So Alzheimer's disease is a medical diagnosis. There are 3 stages we're going to talk about: mild, moderate, and severe. There are some pharmacological interventions such as cholinesterase inhibitors, as well as NMDA receptor antagonists. These 2 classes of drugs do show some moderate benefit in mid stages. And medications that we know worsen confusion in our dementia patients are your anticholinergics, as well as any medication that affects the central nervous system. Next. So age, again, is the most important risk factor in a family history with a first-degree relative. We know that other risk factors are metabolic disease, traumatic brain injury, and less formal education. We know that dementia, even though its numbers are high, especially once you reach the 8th decade, is not a normal aging process. And the cutoff age in the literature between early onset and late onset is 60. Next. So it is a diagnosis of exclusion. There are no current biomarkers or diagnostic tests that diagnose. It's, again, a diagnosis of exclusion. So what we need to do is look for the presence of memory loss, progressive memory loss, but there also must be an inclusion of one of the following: impaired executive function, aphasia, apraxia, or agnosia. And then we need to do a very thorough exam. And this is a comprehensive, thorough, head-to-toe, all systems exam. And in that all systems exam, we want to rule out other potential causes of what's causing memory loss or what might be causing gait disturbance. So we want to look at our vitamin B12. We want to look at our vitamin B1. We want to look for dysfunctional thyroid. We want to do an RPR. And the reason why is because neurosyphilis can present and look just like an Alzheimer's type dementia later in life. And then we also want to consider depression. Depression, especially in the older adult, can mimic dementia. And it also might be not just because of a depression, but a comorbid hard of hearing state. That can actually contribute as well. And so just when we don't think someone's understanding something, they may just not have the actual capability to process it because of a depressed state, or they didn't hear you. So one of the things we can do is a mini cog. And a mini cog is a fantastic quick assessment tool. It takes about 3 minutes. And so you ask them to repeat 3 words after you. And I always ask them to repeat them because I want to make sure that they heard me and that they verbalize the correct word. So I might say apple, house, car, and then they repeat those, and that lets me know that they heard them. And I say, now that you said those, I'm going to have you draw a clock, and I will draw a clock face, and I will say, in this circle, big circle, I want you to put the numbers on a clock, okay? And I want you to put those on, and then I want you to put the time in of 11:15. So then they take the big hand and the little hand. That takes extreme executive function to do a clock draw. And if they're able to do it, great. And if they're not, I have seen every possible clock draw you can possibly imagine. I've seen people start with a 12 and go 1, 2, 3, 4, 5 and go straight down in a line. And they go all the way up to 30. They count all the way up to 30. And then when I ask them to put the time in, they can't. So then I go right back to, do you remember the 3 objects that we discussed a couple minutes ago? The apple, pen, or apple, house, car. And I don't tell them those, and I ask them, do they have a recall? If they have 3 out of 3 recall, you document 3 out of 3 recall, and then you take a picture of the clock draw and you put it in the chart. Because then again, this is a mini cognitive assessment, and then you can actually track that over time. What about people who can't read analog clocks? Okay, I always get this question from students. Then it wouldn't be a applicable screen. It would not be an applicable screen if they couldn't do that. Yeah.
And Jeannie, I was just going to interrupt here. I think we're getting a little bit short on time. And so I was hoping maybe we could finish. Do you have any kind of tips or tricks when students are calling people who have dementia, or like communication with people with dementia, of, you know, how to have a conversation with them, or, you know, ways to redirect, any kind of tips and tricks for communicating with those with dementia?
When you say calling them, you mean communicating with on the phone or working with them?
Yeah, so this group is a group of first-year pharmacy students and first-year practitioner students. And so they're kind of paired up with someone to make calls and just kind of get to know them. And so a lot of them, even though we had asked for patients to not have dementia who sign up, a lot of them we've learned do have dementia. And so they're just trying to kind of navigate of, if you don't know for sure if someone has dementia, but it seems like they maybe have some memory problems, how do you have a productive conversation? How do you not have someone get kind of flustered if they don't remember you, things like that?
Yeah, absolutely. So it's a challenge if you don't know their first 3 chapters. Does that make sense?
Yeah.
No, and especially by phone. You want to try and identify where they are in their notebook. Do they have short-term, or do they have preserved long-term? And are they able to identify, let's say, what kind of medications they're taking? Do they know why they're taking them? One of my most common things I get from patients, I make house calls for a living. And so on top of teaching at CU full-time. And I go to their houses and they'll say, here, I take the blue pill. And I'm like, that's fantastic. Do you know what the blue pill's for? Do you know what it's called? No. Well, thank goodness on Epocrates on our phones, we have pill identifiers, right? So I would definitely suggest trying to identify where they are in their notebook, how cognizant they are by just asking those 2 questions. You're not going to get anywhere with medications or the detail of that short-term piece if they don't know what year they were born or the date today. Does that make sense? Because there's going to be a difference. There's definitely not redirecting people is of utmost importance, especially when they become frustrated, by just validating them, not saying, well, that couldn't possibly be true. You wouldn't say something like that, but definitely working with them to better understand, you know, where they are in their dementia. Are they trainable? Are they? Because are they teachable? And if they're not teachable, then we definitely need to have those conversations with the MDPOA their MDPOA. And so anytime you're working with a dementia patient, it's that's usually their caregiver is their MDPOA, or it may be just another family member or a paid caregiver, but you want to have them part of the conversation always. You don't want to just have this loose conversation on the phone with someone who you know is got a dementia diagnosis. They may not be able to tell you true facts, and then you can't develop an appropriate plan of care.
Is there any way that you kind of can quickly assess if somebody's teachable, or like things that you've seen in patients of, when maybe you need to think about the fact that they maybe aren't teachable? Like, what are some kind of signs that maybe the students would see?
So I work with pharmacists all the time, and they have done mini cogs. Mm-hmm. So cog is a good way to understand. Do they have a 3-item recall? You could just do that instead of a clock draw, something like that, or ask them again today's date after you ask them what year they were born, because again, that preserved older memory compared to present day. I'm trying to think, do you have like, when you're sitting down talking with someone, one of your students just asked a question. I'm trying to see if I can, we're trying to avoid just social questions. So Dana, give me an example of like social questions you're asking.
Hi, Jeannie. I'm one of the faculty in the School of Pharmacy. And so the students have been, we've been helping them, like we have a guide that Sarah had originally created and we edited to ask things about their family, about their former jobs, maybe places they've traveled or experiences. Again, kind of getting into those first 3 chapters that you talked about, but I didn't have really a reference to call it the first 3 chapters. So thank you for that, for sharing. Sure. That was really helpful. But sure. Because they're only in their first year of pharmacy school at this point in time, they haven't had yet all of those therapeutics courses that would help them to kind of field any questions that might come up about medications should they go down that road. Gotcha. with the partners. And so I think what we've learned is that some of the students' partners are very able to have productive conversations because they don't have dementia or a very maybe just mild cognitive impairment. But then there have been other partners that our students have that truly do show some signs of dementia, and so the students have been a little more challenged in trying to have a productive conversation. So that's kind of where we are.
I would recommend starting early and moving forward to present day. So introducing yourself, letting them know who you are, and then asking them, who you are, what you're doing. Mr. Smith, what year were you born? 1948. What state were you born in? And then and you don't do it in such a mechanical way that it sounds like they're being interrogated, but what year were you born? And I just want to verify here on your form. And then they tell you, so now you know that they have that. And then have you always lived in Colorado, or were you born somewhere else? Now we're getting a little bit deeper. We're understanding. So now they tell you where they lived. Oh, what did you do for work? See how we're moving up? And then did you have a family? Now we're moving up to present day. This gives them a little bit more of an opportunity the students an opportunity to understand where they are in their notebook, essentially. Does that make sense?
I noticed that Katie had commented that it makes it a lot harder over the phone with someone with dementia, and in person seems a lot easier. I know you do a lot of home care, and so any tips or tricks you've learned for people with dementia on the phone?
Yes, I have. Well, yeah, because I'm doing televisits the last 3 weeks.
Yeah.
We've had a huge influx of COVID cases in the last week. Again, and so so first of all, I recommend having that conversation with their caregiver if they have a caregiver, that they're on the phone too, and then FaceTime instead of just make a phone call. So I try and FaceTime almost all of my families and their caregivers, usually by way of the caregiver holding the phone. And then we have that conversation, and it goes a little bit more fluidly than it would just on the phone. But again, those questions that I just talked about, starting early on and moving forward to present day, can definitely be executed over the phone, but I want you to consider FaceTime with caregivers too as an option.
Yeah, I would say one of the other things I've learned is that for people with dementia, not correcting them. And so it's not always that, like if they say something that's wrong, it's not always helpful to, especially in these conversations where people are just kind of getting to know people. So instead of correcting like, oh, no, that was last week, just say like, oh, okay. When they tell you that they had their child last week, you say, oh, okay. What was your child's name? Even though you know that none of these people recently had a child.
Yes.
Things like that. I think kind of joining their reality can be really helpful.
Yep. I had just mentioned that a couple minutes ago, where it's very important not to correct them, but you want to validate where they are right now, but then redirect as best you can without appearing condescending or parenting, like for sure.
Yeah, which can be.
The last thing you want to do is reorient someone where they are in their book. For example, if you have someone that's on page 40 of their book, they may be in their, young adulthood, and they won't be able to answer any recent day questions. And they may say, have you seen my mother? Or, find my homework. I'll get that. And you're like, oh, well, I bet I can ask one of the caregivers to help you find it. You almost confabulate with them a little bit, if you would, but just to not trigger them. The last thing you want to do is trigger someone with dementia. They do confabulate stories, but you want to be able to try and maintain your objective by trying to find out the information that you need, and then validating what they're saying, but then redirect. Does that help?
Yeah, I think so. Did anybody else have any questions for Jeannie? Thank you so much for coming to joining us.
Yeah, they were really good questions. Are there any other questions, everybody?
All right, then I think I'll probably just move to, if anybody has any kind of logistic questions or anything else that people, I think I don't want to do breakout groups because I think we'll just run a little too short on time. So maybe we can just, if anybody has questions about how things are going, specific questions about your partners, about logistics, I'm happy to answer them and go through them. And I'll stay on for a while. If people have specific questions. Otherwise, I'm happy to email. I know someone did ask me about grief and how to talk to people with grief.
Oh, yeah.
And so I just wanted to offer, I think the next time I'll go through a few kind of tips and tricks for that, but I really like helpguide.org, has a good helping someone who's grieving page. And so if anybody, Tran attendance is happening right now. So if anybody wants to take a look at that website, then you can definitely do that too. But yeah, looks like Patty's taking attendance. If everybody can make sure that you say that you were here, that would be great. I think most people have already got it.
Did you need me to stay on?
I don't think so, but you are welcome to stay. This is more of the logistics side of things.
I love, I have a master's degree in end of life care from George Washington University. And
yeah.
I took many classes in grief and bereavement, and I am so elated that you're covering this.
Great.
So I love it. I just want to say thank you for inviting me.
Yeah, thanks for being here.
I hope you guys learned something.
I actually did have a couple questions for you, for Jeannie, if you had the time.
Sure.
For the Lewy body versus Parkinson's dementia, is the mechanism of action the same, and it's just the timing that it shows that differentiates it, or is there something else?
That's a really good question. It's actually not conclusive right now. They do think that they should not be actually differentiated. There's a lot of literature that says they should not be differentiated, but they still are being differentiated. In terms of Parkinson's dementia is in fact a type of Lewy body dementia. But as you said, Charles, it's all about the onset and trying to determine what came first, the chicken or the egg, or the motor dysfunction or the dementia.
Okay. The second question was for the sleep and the glial cleanup.
Yes.
Is it not enough to maintain as you get older and then they end up falling into Alzheimer's, or how does that work? If there's enough cleanup, then wouldn't it just revert back to the nucleated portion and then not have symptoms?
Correct. So we're looking at, so the people that are highest risk are people that have sleep disorders and that have depression. Clinical depression causes sleep disorders. And so untreated depression is one of the risk factors for developing later in life dementia if it's not treated earlier in life. And then the other thing I wanted to mention, I did not mention another, so we talked about sleep as a protective factor, but the other thing is diet, because almost 80% of all post-mortem autopsies, 80% of post-mortem autopsies for patients with Alzheimer's type dementia have massive inflammatory signs of inflammation and chronic inflammation in their central nervous system. And so we know that the Okinawan diet, the Mediterranean diet, that being mindful of your treatment of hyperlipidemia, hypertension, and hypothyroidism are of utmost importance too. I just wanted to add that in.
Okay, thank you very much.
Thank you. Okay, thank you.
Thanks, Jeannie. All right. Any other questions anybody has? Everybody is able to get in touch with their people. Any problems with communication or anything?
I have a quick question. I sent it in the chat, but realized I think I sent it directly to one of the other students. So sorry to Katie. But my question is, it's sort of more theoretically, more like it hasn't happened to me, but I could see it happening with the current state of affairs in our country. If you have your patient sort of wanting to engage with political conversation, what's the best way to sort of navigate that?
Yeah, great question. This has come up a lot for me too recently. So I think a couple of my strategies. So if it seems very clear that they and I don't align politically, which happens sometimes, then I usually just say, you know, I just don't want to talk politics. Like, I'm going to stay out of that realm. I kind of make it a joke like, oh, talking politics is dangerous. Let's move on. And then I just move on. And I'm like, anyways, how's the weather? How's this? How's that? I also find that if people are feeling stress or anxiety surrounding politics, you can talk about the anxiety without talking about the specific political opinions, which I think can be helpful too. And then some of my patients I align with politically, and sometimes we do talk about politics. And so you just kind of feel it out. I mean, there are people that have told me, you know, like, I feel scared for myself or my family, or, you know, and I can understand or relate. And so sometimes I do talk about it. I try not to ever get into an argument. I think in general with politics, arguing about politics is rarely ever successful, especially in how divided the country currently is. But I think you can just like listen and, you know, say like, yeah, I hear you. It sounds scary, kind of reflect back how they're like, if someone's talking about a certain political thing, you can say like, well, it sounds like you're really scared or really frustrated or really whatever, and understand their emotion without explicitly agreeing with their political views. And so I'll say, yeah, it sounds like you feel really scared that this thing is happening, or it sounds like this has been really stressful. And usually they'll say yeah, and then you'll say like, and then I think it's okay to say, you know, I'd probably rather not talk politics. I try not to do that in my day-to-day life, or whatever you want to say, and then move on. And people usually respect that pretty well, especially if you're not directly directly disagreeing with them. I think that's when it gets a little trickier.
Thank you.
Is that helpful?
Yes, thank you.
Okay, yep.
Okay, let's try this again. Can you guys hear me?
Yes.
I'm on my phone and it keeps cutting out. But I have a question if it's my patient, because I can't get him to talk. Like, he just wants nothing to do. Like, hey, how's your day? It's awful. Like, I don't know how to handle that.
Yeah. What have you
Like,
tried so far?
I've asked him, like, did you do anything over the weekend? Oh, I played bingo. Oh, that sounds like a lot of fun. Did you have fun doing it? No, I lost. I don't know how to handle him.
Yeah. I think it's okay to sometimes call people out a little bit. And so you can say, hey, we've had a couple conversations now, and it seems like maybe you're not as interested in talking, or maybe I'm reading that wrong. Is there anything you're really hoping to get out of these conversations, or anything you'd want to talk about? Because sometimes people just don't realize they're being short. Maybe they feel uncomfortable, or they're like, and so maybe then if you say like, oh, it seems like you haven't, it seems, or you don't have to say you haven't, but it seems like maybe we haven't been able to, really start like a good, deep conversation or connect. Yeah. And so is there anything I could do to make that better? Is there anything you're hoping to get out of these conversations? And maybe they'll say, no, I don't want to be a part of it. Who knows? Or maybe they feel uncomfortable, or maybe they're like, well, I don't know. I thought I was just supposed to answer your questions.
Okay.
Or maybe
Yeah.
sorry, go ahead.
No, I was just saying he's doing a really good job of just deflecting. Like, oh, my back really hurts. I need to go lay down now.
Yeah. And
it's been like 3 minutes.
Yeah. And so I think you can say like, or you could say like, hey, I really want to get to know you. Like tell me about yourself, and like leave it open-ended a little bit more, so that it's a little harder to say yes or no questions. You could also say like, well, I'm hoping we can get to know each other more. Is there anything you want to know about me or about my past? So then you could share a little more.
Mm-hmm.
It's hard when people don't want to talk, especially when the whole goal is just to talk.
Yeah. I just feel like it's just been a struggle. Like, if I can't get him to answer the phone, which is problem number one,
Mm-hmm.
it is literally 2 to 3 minute conversations.
Yeah.
Hey, Ruth. I was going to jump in.
Yeah.
This is Dr. Hammer. You might have mentioned this already, and maybe I missed it. But had you already asked him about like some of the early chapter kinds of questions, like, oh, where you were born?
Yeah,
and some of that stuff. Okay.
Yeah, I mean, we had a great conversation. He's like one of 8 kids, and his family's all from New York, and he moved out here to be closer to his sister. And well, my sister didn't bring me cigarettes over the weekend, so now I'm just grumpy.
Got it. Yeah. Sometimes it's just tough, right?
Yeah, I'm finding it to be a struggle when like I have, an uncle who's in his 80s, and it's just so thrilling for him to talk to family. Like, I struggle, I guess, with that connection, and I never really have had that in my life where I've never struggled to have a connection to someone. Like, that's what I've always enjoyed. Like, my patients in the pharmacy are like, oh my God, you're working today. It's so good to see you again.
Yeah.
Like,
yeah.
I feel like it is a struggle over the phone.
I feel you, because I think I've had similar experiences, and it is hard when you come across someone that just does not quite engage. I would encourage you, not only with what Dr. Teets talked about, but if there's anything to kind of take him back to earlier in life where maybe he's got some happy memories, like, oh, tell me about your favorite things you like to do when you were a kid, or any sports you played, or favorite vacation you took with your family. I don't know. Sometimes I think getting back to those happy memories as a kid, if they had those.
Nope.
You know what I mean?
My childhood sucked.
Okay. Yeah. Well, thanks for trying.
He's just a really grumpy guy. So I'm like, I think there might be some anxiety. He's going out for hip surgery next week, getting a replacement. So I'm hoping I'm going to keep trying. But.
Yeah.
I mean, I think the other thing to remember is that, so people with like autism spectrum disorder or personality disorders, those things don't go away as people get older. And so maybe this is somebody who has like autism spectrum disorder that's mild, formerly called Asperger's, or, you know, maybe he has something like that. So he just doesn't really understand social cues. And so possibly he thinks this is a great conversation, that you guys have really gotten to know each other, that you ask questions and you've cared about, like maybe that is how he feels. It's hard to know for sure. But he must have wanted some kind of interaction because he signed up. So
Right.
maybe you're doing more good than you realize.
I really hope so, but I just feel like I've never struggled with just connecting to someone like this before.
Yeah.
Usually I can always find some kind of common ground. So
Ruth, this is Kim. I have to give you top kudos on just something you said about 37 seconds ago. Could this possibly be the patient displacing because of internal anxiety over an upcoming hip surgery? How old is this gentleman?
61.
61.
63.
Yeah.
I have it written
60.
down.
That's okay.
I'm on my way to an appointment. I'm like, I can do this.
That is a huge pickup. A lot of patients are going to feel that way, but they're not going to tell you that, because especially a guy, because then his ego gets affected. You know, guys have to be able to handle everything. And then
Oh, yes.
taking in that culture piece, plus the gender piece, plus any ethnic piece that could be interplaying in here, you may have just hit it on the head. Coupling it with what Sarah just said, you may have just nailed it. And then he's going to get out of surgery, he's going to come back, and your phone call is going to be even more important after he comes out of that surgery and is back. It's amazing. So kudos to you for picking up on that.
Yay.
And I'll say this, the fact that you've sat in this uncomfortable conversation and tried all these different strategies, even though it doesn't feel good, like you're learning a lot of really valuable communication skills, and it will 100% help you be a better pharmacist, because you're going to have people that come like this that don't really want to talk, and like how to engage people without pushing too hard. It's like a really fine balance. So the discomfort is probably a really good thing, because you're learning a lot through it, even if it doesn't feel good. But I think you're doing a lot of the right things.
I'm starting to develop anxiety before calling him, because I'm just like, oh, it's just so hard to like, I don't want to just deal with like negative vibes. And so it's like, I force myself. I'm like, okay, I have this thing. I call him, you know, on Thursdays on my, you know, today's Thursday. I call him on Wednesdays during lunch, and it's just like.
Yeah. And I would say respond to his emotions, not his words. So when he says something, say, oh, it sounds like you're upset about that. And then make him explain that. Or he might say, I'm not upset about that, and say like, oh, I guess it just sounded like you were. And so maybe try responding to his emotions, not his words.
Okay.
Yeah, that might be. But anyway, let me know how it goes.
Yeah, cross my fingers, because he's got his pre-op and then surgery. And so I'm going to try to catch him between the two.
Perfect. Yeah, that's great.
Oh, God, I really do hope him the best.
It's doing more good than you think, I bet. All right. Anybody else with any questions? Everyone else is free to go, but if anybody has questions, I'm happy to stick around and answer other questions.
Sarah, I'm going to stay on and talk to a student.
Oh, I really appreciate that you guys had this presentation today, because I was one of the people that stayed back last time and was like, you know, my older adult has memory issues, and like, how do I not make her upset? And so this was really helpful. I guess the issue I'm running into now is I don't mind talking about the same stuff with her every time, but I just don't really know what the goals of this project are now, where we're kind of like, I've kind of learned her backstory, and she enjoys talking to me, but then sometimes I can feel that she's like, okay, like she'll start to remember that we've talked about this, and then she'll like kind of be like, oh, I need to go now. And then I'm like, okay, that's fine. You know, this is really for her. But like, what other things, I guess, are we supposed to be implementing other than just chit chatting?
Yeah, Kim, I see you shaking your head. Do you have thoughts?
Michelle, you are so sweet for asking that question. And it's actually a really high-end critical thinking question. So my students that are still on here, they're well aware that there are different types of communication styles. And one of the main purposes of you engaging in this is learning how we as practitioners check our emotions and stay in a moment. and you're learning skills that may not seem very valuable right now to you because there's so much underpinnings of education that needs to still come for you for what this is actually going to be of value for you. I'll give you an example. I saw a patient yesterday. I've been trying to get her into the clinic for 6 months. She came in yesterday, sat in the chair, and stared at me. I had 9 different major comorbid medical problems that I needed to discuss with her. She's on 9 different pulmonary meds. It's like, what the hell? Polypharmacy here. Who did this? And I'm trying to figure all this out. And she'd answer yes or no questions. And then I would ask the question a different way. And part of the learning of this is understanding that we may have to ask that same question 7 different times, 7 different ways to get one answer. So for you, it could almost become like a puzzle. Okay, so I asked this question last time I saw the patient. I'm going to change up how I'm asking the question, see if I get the same responses. So it's you working with yourself, changing up how you ask questions to see if you get the same response. Do you get it if you change it this way? Do you get it if you change it that way? And it could help you get a real nice arsenal of ways of asking patients questions using a high emotional intelligence format where there's no defense, there's no attitude, no emotion. It's just learning the process of asking. There was a 45-minute appointment yesterday and I was in there for 90 minutes. Yeah, my whole day went to hell after that. But I got my answers, and when I was all done, this is what the patient said to me. Just so you know, you're the first person who took the time to talk to me. Thank you. And it was like, did you just say thank you? Really? And then she went ahead and gave me a hug. I know COVID, I had to take my clothes off when I got home, but it meant that much to her. So I don't know if that little piece helps you, but you're honing your skills of talking, even though you're asking that same question 7 different ways. And the students that have been with me in clinic that are MP students and farm students, you're more than welcome to come spend a day with me in clinic and see how we change up these questions if you want. But they've seen how I have to ask the same question 7 different ways or 9, stop the question, go on to something else, and then come back again so I can get an answer so I can do something that I'm supposed to do. So that is a good question. It's a really high-end critical thinking question. And it may not be what you are expecting, but the skill sets on this are really going to be very valuable to you, more than likely in that 3rd semester of pharmacy school.
Okay. Yeah, thank you. I appreciate that. Like, I think I have, tried because obviously I don't really want to talk about the same things. She doesn't realize that we probably keep talking about these same things. And I guess what I'm getting at is like I feel like I don't know. Yeah, I mean, I guess I can try just still changing up the question to elicit some different response, but maybe I'll learn more after if we have the grief presentation, because like I feel like a lot of her past life is sad too, so then like I try not to really go there, and then I just feel bad that we're kind of talking about the same stuff every time, and then she kind of remembers. She's kind of like in this middle ground between like not remembering and remembering. Like if we talk about something for 5 minutes, she'll be like, oh yeah, I remember you have 2 cats now, and she'll ask me every
So
time.
she's on page 54 or page 49.
Probably. Yeah.
Michelle, I'm going to tell you, don't be afraid. You can just say to her, your voice sounds so sad. Tell me about that. Why is it sad today? And don't be afraid to say these things, because if you're hearing it and she's feeling it and she knows, she may or may not know she's saying it, you making that little connection may open up literally a cavern of things that she just wants to talk about. Do you have a second to hear about my dog? I'm really sad about my dog. And it may be like, well, didn't you just tell me about your dog 2 weeks ago? Yep, she did. But she needs to talk about her dog again. So don't be afraid of that. And I think you're probably doing more, like Sarah had said before to Ruth, you're probably doing more good than you realize. You just don't realize the benefit of what you're doing because you're not personally feeling it or getting that personal reward the way you've had it before. This is a different type of reward that you're getting with the learning that occurs with this. I do believe, though, that there'll be an aha moment from you sometime in the future. It's like, oh my God, I'm so glad I did these 600 phone calls that I'm doing. That's exaggeration.
Yeah, that's actually, I was thinking about that. Like there will be some point where I'll
Yes,
be
it'll
like,
be that one patient.
I'm like used to
Yes.
having these long, awkward conversations, you know, like one day that will happen.
You know, it really will. And one patient out of 100, this may be a benefit to, but that one patient is the patient that needed you that day in that moment for this issue, because you may just save that patient's life. You may just keep something from happening that was bad. And we don't know what it is. My students know it's called domino falling. Dominoes fall specific ways for specific reasons. There's a specific reason you're here right now, but the domino hasn't fallen to show you that purpose. It will. And then it's going to be like, thank God CU does this.
I I know I had a patient last week who has moderate dementia, and she like half remembers our conversations, and her and I don't really talk about her meds because she can't manage them. So I just call her daughter after and tell her daughter what we're doing. And I just, so like, I was like, ah, forget it. I'm just going to listen to her talk this time. Like, I felt like it was kind of an unhelpful meeting. Like, I didn't really get any medical information. I already knew all the things she told me about her history because we've talked about it before, but I was like, I'm just going to, like, today she seems to just want to talk to me. So, like, we're just going to sit here and talk. And afterwards, she was like, I've never felt like a doctor cared about me enough to just listen to me. And so I think just like bearing witness to people's experiences and caring enough to listen is really powerful. And to us, it doesn't feel like that because we listen to people all day long. But just like taking the time, the fact that you're willing to take the time, willing, forced, whatever you are in this program, but the fact that you are taking the time to listen to her and care enough, I think is a really, really powerful and important thing. And on our side, it doesn't feel as powerful, but to have somebody who she doesn't know care enough to keep calling her to just listen to whatever story she wants to tell is really, really powerful and meaningful. And so I think that that's probably more powerful and meaningful to her than you can feel, because it doesn't feel as meaningful to you when you've heard the same story 4 times. But I still think that she probably feels a lot more cared about and a lot more like in touch with others in the world, if that makes sense.
Yeah, I guess like my original question wasn't like, you know, I feel like it's, you know, I'm not getting anything out of it. It was more of just like, I don't know if I'm doing this project correctly.
You are.
Like
You are.
Yeah.
Michelle, there's 2 things with you being a pharmacy student. I'm also part of your School of Pharmacy. I'm taking classes right now for integrative health and medicine. I'm getting my butt kicked right now. Unbelievable. You guys are like incredible to be in the School of Pharmacy. I just have to say that. But I have 2 things to share with you. There is something that nurses learn, and it's called whole systems communication. And there's 2 aspects of listening that practitioners use. So I'm going to share them with you, and you can go look them up. One of them is called deep listening, which is actually what you're doing, and it's a skill and an art. And the second part of deep listening is called attentive listening. And the attentive listening is kind of what the psychiatrist was talking about last month when she was talking about things that people say, don't say, pauses and types of words, tonage, cadence, things like that. And there is value in that. But if you just want to take maybe 15 or 20 minutes out of, your bored Sunday coming up when you have nothing to do, just take a look at the definitions of those. The University of Minnesota Whole Systems Communication has an absolutely fantastic website that you can go in and just kind of look at some pieces. Part of what you're learning with this and what you're actually engaging in are those 2 pieces, and they really are going to help you become an exceptional pharmacist moving into the future, where I, as an NP, calling you and saying, Michelle, I have a problem with a patient. I need some help her. I am not sure what's going on, blah, blah, blah. And you're hearing me, but you're also hearing the anxiety in my voice and the fear in my voice that I don't want to say to you because I'm a professional and I'm a provider, but I feel scared. I have anxiety. Am I making the right decisions for prescribing? Am I going to hurt this patient? I don't want to do that. And you're going to pick up on that, and you'll change your words to meet my need. And that's some of the stuff that you're learning with doing this. This stuff doesn't get taught in textbooks. It doesn't. And learning it on the job, you don't have time. You have so many other things that you have to do in your role as a pharmacist. So this is a wonderful opportunity to gain a skill set that we don't really have classes on, but is going to be like a cornerstone for you to be like the best pharmacist ever. Not just because of your skill set, but by how you communicate to people.
Awesome. Thank you for that. I'll definitely read up on that. And yeah, like I just think that's even helpful, just like learning something and then, you know, I can try and implement and practice. So thank you.
Yeah, there's no like right or wrong way to do this. It's just to talk to people and learn what that feels like. So you're doing it right.
Okay, cool.
Anybody else with questions? I see there's a couple people left on the call.
Well, I guess I should have said that before when everybody was on, but I'm having a great time with my patient and she's great and I love her and I talk to her every week and she talks about everything or about the same thing or whatever she wants to talk about. I'm here for it. So I just want to say thank you for doing this program. Like at first I was like, oh no, another thing to do. But now like I'm so grateful. Like she's the best. She's just became like actually my friend. So, yep, I just wanted to share that.
Well, I appreciate that. I think that's what we're all hoping, that everyone can have a good experience. And so it's really nice to hear the good feedback. Thank you. All right, Matthew or Taylor, see you're both still on. Any questions you guys have?
Nope, all good. Thank you.
All right, thank you. All right, well, I think then we'll head out, but thanks everybody. Kim, Patty, Lisa, and do we have another meeting?
I don't think we have anything on the books right now, but I can share with you that the only issue that the NP students have had is not anything that's major related to how we've got things going, but it's Epic. Epic has been a bear. And we actually have our director of IT now involved. Matthew was somebody that got really significantly affected.